This program is a presentation of UCTV for educational and non-commercial use only.
Technology is transforming how we manage diabetes, the way we test and track our blood sugar levels, the way we take insulin, and the very makeup of the medications we take are all changing super fast. Stay tuned. Welcome to Taking Control of Your Diabetes. Advances in technology are making diabetes management not only easier and more convenient, but also more effective and safe. The cures for type 1 and type 2 diabetes may not be around the corner, but the progress in diabetes technology will allow us to stay healthy until the cures are found. With me today is my good friend and colleague Ian Bloomer, who is a diabetes specialist from Toronto, Canada. Dr. Bloomer is a passionate believer in patient education, which is why he comes to a lot of our conferences that we put on around the country and why I like him so much. So Ian, thanks so much for joining the show.
Oh, it's a pleasure, Steve. Thanks for having me on.
Now, I hate to admit it, but you and I have been in practice for well over 25 years each, and I think we've both seen a tremendous advance in diabetes technology.
Oh, it's incredible. You know, when I look back at second year medical school, I remember like yesterday having a lecture where we were taught how to adjust therapy based on how much sugar was in the urine. I mean, that seems like Neanderthal times. It was just so archaic compared to what we have nowadays and what's on the horizon.
As we jump into all the new gadgets we're going to talk about, some of our viewers may need to be educated a little bit. This was the very first glucose test strip where you took a huge drop of blood, put it on here, and sort of held it up to a color chart. And then we got advanced. We got little glucose meters that actually give us measurements, and we still have to use a finger sticker. In the olden days, we took a little sharp pricky and we actually jabbed our finger, and you had to do this several times a day. And nowadays, it's, you know, these finger stickers were quite nice. You hold on to your finger, you prick it, you get a big drop of blood, you put it on the strip, you find out your number, whether it's good or bad. If it's good, you show it to all your friends. If it's bad, you throw it in your pocket. And you take care of your finger. Now, I think that's a great stepping point into some of the newer models we have for pricking the finger. And I think one of them is a device called the Pelican Sun. And in fact, I have one here. Maybe you can fill me in on what's this about.
Well, it's very cool. I know you and I both tried it, and it's really quite innovative. It uses a very different technique where it actually can precisely measure how deep the penetration is going to be. So it actually doesn't reach deep into that rich nerve layer, which is where so much of the discomfort comes from, and it actually allows the blood to flow more smoothly to the skin rather than pooling underneath the surface. When I look at that type of technology, and really all it is a very sophisticated way of getting a blood sample, and I keep thinking, you know, there's a trade-off between something like this, which is small, compact, and virtually free, except for the strips, of course, the device, versus something like that, which is heavier and larger. And so, you know, I look at the pros and the cons and say, sure, there's no discomfort, but there's a bulkiness to it and a weight. We don't know about cost yet. So I'm not sure where eventually it's going to find itself in the market, but it'll be interesting to see.
And I think with all the technology we talk about today, I think miniaturization and combination is important. And talking about combining devices, what's going on with this Intuity device?
One of the things most of my patients tell me, Steve, I'm sure your patients tell you the same thing, is they carry so much stuff. Right, like half my patients come in with a purse full of stuff, or the guys, you know, with a, you know, the briefcase full of different things. Living with diabetes, I don't have to tell you, is so tough. We have to find ways of making it easier. So with this combination device that this company has developed, basically it combines the Lancet holder, the Lancet, and the tester into one single device. And I thought, you know, on first blush, I thought it looks like it might be something that my patients would like.
Well, even when deciding what of the many technologies we're going to talk about, I thought, well, gee, is that really a huge advance? It actually makes life convenient. And if we can make life convenient for people living with diabetes, it'll improve diabetes care.
So I think with this new device, the OnQ, I think in that way it'll be nice. I see it as an incremental change. I don't see it as a paradigm shift in quotation marks. But you know, anything that we can do that makes life easier for our patients is something that I'm in favor of. So I'm hopeful that that device will indeed serve that role.
Yeah, so do I. Now, what we've talked about so far is here and now. But I think a huge advance in diabetes technology will be the whole concept of non-invasive glucose testing.
I think it's going to make a huge difference. I think for a couple of reasons. Number one, if people don't have to prick their finger, get the blood sample, go through the different steps like you've just illustrated, I think they'll like that. Convenience is a very important limiting factor, the absence of convenience. And if we can have our patients follow steps that make life easier, I think they'll be more likely to be aware of their glucose and keep an eye on it. And I think the other thing, the other component to it, as non-invasive, non-finger prick testing gets better and better, it's going to be easier to access this information. So my poor patients, I'm always amazed, Steve, how much I ask my patients to do. And so many of them do it. I have my patients checking their blood 5, 10 times a day, and they do it. And I think, bless you, I can't believe how much effort so many people are willing to invest. And that's to get blood, to check their glucose 2, 3, 4 times a day. And then I keep thinking, in the overall scheme of things, that's like trying to read a book by reading one word per page. And I keep thinking with these non-invasive meters, the next generation perhaps, you're going to have hundreds of readings available to you on a continual basis. So it'll be both the convenience and the additional information. And so much of diabetes management is about having the information available.
We have continuous glucose monitors. Where's mine? I got my little blood sugar here. This requires that I stick something under my skin. It gives me a blood sugar every 5 minutes, a topic that we'll discuss later on. But non-invasive is going to really be appropriate for the masses, for folks with type 2 diabetes on oral medications who are really not candidates for continuous glucose monitoring. And think of all the kids, browbeaten by their parents, test your blood sugar. And I think you talk to any parent of a young kid with diabetes, they'll tell you, first of all, it kills them to make their kid prick their finger. And second of all, they need more information so they can adjust the insulin.
And I think once we have non-invasive testing that is easy to use, reliable, giving all this data, I think we'll look at what we're doing right now compared to that. In the same way I look back and laugh at what they taught me in medical school in the 1980s about helping people with diabetes by doing urine testing. I think that will be a paradigm shift in what we do.
Well, tell us about the Centris 100. Just to jump in there and say that there were too many to count companies working on a non-invasive glucose meter. And because not only is it big bucks, it'll also help a lot of people. So we haven't gotten to an accurate and durable and reliable one yet.
Not yet. Now, the Centris 100 device is a bigger device. It's not really for home use. It's really for hospital-based use, and you have to be connected to a pretty hefty size device. So I think it does look encouraging, but I don't think that is the particular type of non-invasive glucose measuring device that we'll be seeing, in home use in the workplace in the near future. But so many people in hospital need to have glucose levels checked frequently. And nurses devote so much time to that. And it's a real limiting factor in helping people in hospitals. So I think that type of device might be great.
What they really need is a reliable one that gives glucose measurements throughout the day and night, especially when someone's critically ill, they've been through an operation. So I think you're right, that might be the first step. And then of course it's miniaturization. What about the ORSense device?
I think the ORSense looks very promising. They're working on a second generation. They have some good scientific data suggesting their first generation device works well. And I think they really used lateral thinking. Rather than the idea of just, pricking your finger, getting blood or whatever, they used light. And this device, the future generation one, you'll wear the equivalent, if it comes to fruition, like a wristwatch. And it's got a little attachment that you wear like a ring on your finger. And it compresses the tissues gently, not like an excessive tourniquet. It compresses the tissues, and then they shine a light in, and they find the way that the photons, the particles of light, the way they bounce around inside the tissues, can then be measured. And the way that these photons bounce around can indicate what the glucose levels are. And I think that would be, way cool as a technology. But
So the operations manual is a physics manual, basically. Photons, or is that chemistry?
I hope it's shorter than that. No, but I think that's not just in the ideal, theoretical abstract. I mean, they do have a device that, in prototype at least, seems to provide the information that you and I, cherish, that our patients would cherish.
Let me show you the Census device. Now, don't be shocked when you see the size of this thing. It's fairly large. It's obviously, not portable. And this is a prototype of a working model, just like the ORSense. They've gotten very good information. And basically, they use a technique called mid-infrared spectroscopy. And it measures the wavelength of glucose across the skin. Now, you can imagine the technological challenges. It has to measure it just at a certain depth. It has to go past other interfering surfaces like the skin, the subcutaneous fat, other fluids. And so basically, you take this device and you put it on your skin, and it literally takes 10 to 15 seconds, and you can come up with a value. And yes, they are working on miniaturizing this model, but let's just say this is the device that's going to come out once it's approved.
For what I see, this in terms of what excites me about this isn't, this physical bulk. I mean, clearly this is, in an early generation. What I find exciting about it is it shows there's a technology in the here and now or near horizon. And sure, it's big like that. That won't stay that way. It'll get smaller and smaller. So sure, I think if that came out just like that tomorrow, sure, I have hundreds of patients that would find it a helpful tool. But I have thousands of patients that would look at it and say, Dr. Bloomer, call me back in a year or two when there's a smaller device that I can really use in the way that would maximize my ability to benefit.
Once patients get a lot of information, that brings up the whole topic of artificial intelligence. And because, creating lots of numbers is one thing, using it to improve your diabetes control is another.
If I had a patient who has 5, 10 readings, that's enough complexity. If they have hundreds of readings from these measurements, then how are they going to incorporate that into behavior change to stay healthy? But imagine if we had a computer model, either through the internet, on a little handheld device or whatever, where people can upload that data. And
you're talking about the iPhone technology where they have applications for people with diabetes right now.
Absolutely. And in fact, I noticed that there's a new app for the iPhone where you can actually do something like that. You can upload, it says, it's not quite that holy grail as yet, but you can upload some of your data and you can enter some additional information and it can, graph your readings and so forth. But taking that, beyond is where it actually, you can input, if you don't mind sharing with your, the AI device, what food you're eating, the exercise, and it would be ideal if it could then tell the patient and say, based on the information, based on your glucose, your exercise, what your glucose trends have been, consider adjusting this insulin dose. Maybe you need a different dose to this pill. I would hope that it would then say, speak to your healthcare provider.
Sure it would.
They need to have appropriate disclaimers. But again, the point is, this isn't something 20 years from now. This is on the near horizon, and I find that so exciting. And I can tell you, the people that will be almost excited as my patients are docs like you and me and our diabetes educators. I mean, I spend, as I'm sure you do, hours a day trying to help people understand what kind of changes to make, because I want them to be empowered.
Yep.
If this is a tool available to them, it would be a huge boon, not only to people with diabetes, but those of us helping people with diabetes.
Yeah, and I think a lot of patients don't put diabetes on their own personal priority list enough. And seeing the numbers, getting some positive feedback, making those changes and seeing the results, I think help them get more interested in their own diabetes. Let's turn to insulin and how we get it in our bodies. We know that insulin itself is a peptide, a protein, and you can't just swallow it.
As you know, they've tried every technique in the world. I mean, they've tried pills and sprays, which perhaps we'll talk about, and creams. They've even had rectal suppositories of insulin. As I say, if there's an orifice that you can use, they've put insulin in there to see what would happen.
And other drugs as well.
And other drugs as well.
Since insulin became available, we've had to inject it. In the old days, crude needles that we had to sharpen with emery boards, to really nice, super small needles. Now, I'm going to start off with one advance. It may not be the world's hugest advance, the computer on the shuttle. However, it makes people's lives easier and it allows them to follow their diabetes regimen. This is called the iPort. And basically what it is it's a little port that gets put in under the skin. It's a catheter, it goes in with a needle. Once it goes in, the needle actually comes out. Whatever you're injecting, whether it's insulin or Symlin or other medications, you stick it in and you can give yourself an injection. It stays there 3 days. And I know some of the things we hear from our patients that, oh my God, I'm tired of poking myself.
Right. Well, that's interesting. It's sort of like my patients who have a pump. And I say, with a pump, you're going to inject yourself every 3 days in a sense, because that's when you replace the inserter. So I think for some of my patients, I could see where they would actually find that a very welcome change. Again, I would see that as an incremental advance, but incremental advances are fine if it's going to make the life easier.
If you're on a basal insulin, let's say Lantus or Levemir, you might be using one of these nice insulin pens, and then you're on a fast-acting with every meal. But if you're high in between meals, you got to take a little extra. And if you're on a drug called Symlin that's available in the States, that you have to take that with each meal, and that could be up to 10 injections per day. So it's really a simple but practical advance that helps people take better care of themselves. Let's go into the future and talk about inhaled insulin. You and I are quite familiar with the first inhaled insulin that was on the US and Canadian market. This was made by Pfizer. It took them 15, 20 years to get this approved. This is the inhaler device. You put a little freeze-dried tablet of insulin in, you squeezed it, it aerosolized it, and you took it in. And it worked quite well. They had long-term studies showing it was safe and effective. However, Pfizer, a pharmaceutical company, pulled it from the market. They weren't selling.
And other companies, withdrew their research. They stopped.
Yeah.
There were so many companies, and they decided, and it seemed not to be a safety issue, as you pointed out. It just, they thought it wasn't going to be profitable enough. And so virtually every company except for one abandoned where they were heading.
Let's compare the devices from the Pfizer device, which is basically, this is the real actual device, and this is a prototype of the new inhaler. And it's a company called MannKind. They have a very effective insulin that gets inhaled. It snaps, goes into this little device, it snaps in, and once you push a button, it gets aerosolized and you inhale it, and you can use different strengths of tablets. Many patients will not advance the complexity of their care in terms of number of injections because, and you can't blame them, they're just tired of sticking themselves.
And I think that's one of the hallmarks, right, with diabetes care. It has to not only work and help people, it has to be something that's going to be practical, that people are going to actually use. If it's some sort of exotic complex therapy that's overly bulky, people are going to have a hard time accepting it. But I think this is very cool. I'm looking forward to seeing where this ends up.
Yeah, and it just so happens that the information that they presented to the FDA, that the rapid onset of the insulin that you inhale is very rapid, which is a good sign, which is a good quality for pre-meal insulin, and it also gets out of your system quicker. It leads to less hypoglycemia. So there may be some pharmaceutical advantages besides just the fact that you don't have to inject it.
Well, that would be excellent because, of course, what we're trying to do is have, in addition to a long-acting insulin, for most people, for many people, certainly those with type 1, it goes without saying, that people need an insulin that's going to work really quickly because that most closely simulates what, of course, what the normal pancreas would do.
And that's what it's all about, is mimicking the natural state.
Right.
And why don't you tell us about this substance called Orlin?
But I thought this was interesting. So it looks like an asthma inhaler, but it's not. It's actually not to...
It looks very much like
it does, but it's actually not to give the insulin right into the lungs. The insulin actually goes on the inside of the cheek, which I thought was very novel. So you have to shake this up a whole bunch of times, and then, just for illustration, I'll point to this direction. But it's got a big... it's a whole bunch of stuff that comes out. Now that's the equivalent, at least in this context, with this prototype, of 1 unit of insulin. So I don't know in the future if there'll be additional types, but I thought that was interesting. And again, if this proves in subsequent studies to be safe, effective, I think it's certainly got the convenience factor. So again, it's one of those things that I think could influence behavior change, right? It might make people accepting of giving insulin that perhaps wouldn't be otherwise.
Let's turn to insulin pumps. That's another way of getting insulin into our bodies. And I wanted to first show a traditional pump. This is an Animas model. This pump houses a cartridge full of insulin. This is the catheter that goes under the skin, and patients have to pretty much have this hooked on all the time, and they program in their different doses. Now, relatively new on the market, and something that I'm actually wearing now, is an Omnipod. It's disposable, tubeless insulin pump. Mine's right here. That's not my tricep. That's actually my pump. This holds 200 units. You pull off the little stickies, you slap it on different places, and this controller directs the pump to give yourself insulin. Of course, you yourself, as the patient living with diabetes, determines the dosage. So these pumps are on the market now. We had a previous show on pumps, and I'd encourage our viewers to look at it if you're interested in pumps. And what's almost on the market are these whole concept of patch pumps. So here is a Valeritas Vigo, and maybe you could tell us how you might think this would be
Sure.
important.
So it's interesting. You know, we were talking again, not that this is a more sophisticated device than the Omnipod or other pumps. In fact, in many ways, one could say it's less sophisticated. But what it has is convenience, because you put this on and you wear it, you know, once a day, and you replace it every day. And it doesn't have all the you know, the mechanics and the computerization and the sophistication. But on the other hand, it's convenient. So you wear it, you take it off at the, you know, after 24 hours and you replace it. And it just supplies, and I think this is an important point, it's designed to provide the background insulin, the basal insulin as its main role. And they'll have different, you know, different strengths available so that it can infuse the insulin into your skin at a different rate. So you'd have to know that in advance. So it wouldn't have all the nuances and complexities that some of the other pump devices do. And that's good and bad.
This pump, and several other companies are developing similar ones, is specifically going to be marketed towards people with type 2 diabetes that need mealtime insulin. So we know people with type 2, they do well on pills. They might do well on pills and then one shot of a long-acting basal, but a lot of folks with type 2 may need to give themselves insulin before each meal, and you hit it on the head. I mean, it's simplicity. There's no batteries, there's no components, and it's meant to fill up, pull off the sticky, slap on. You can give yourself boluses by pushing on a button versus a controller. When the 24 hours is up, you put on another one and you fill up maybe 5 to 10 at one time. Now, getting back to the continuous glucose monitor, we've been using these in clinical practice. Once again, it's a device where you put something under the skin and it measures the glucose every 5 minutes using traditional, like glucose oxidase, sort of like the technology we use in our little glucose meters. And it's primarily now for people with type 1 diabetes who have had problems with their control, who do not sense their low blood sugars. This basically is part of a system that we call a open loop system where, you know, I'm the user, I see my number coming down from after lunch, and I've given myself my extra dose. So I made all the decisions myself. And that's what we call an open loop system. What's on the horizon for closing the loop?
It does all the thinking for you.
Yes,
and
exactly.
And that, you know,
Thank you. I couldn't think of it.
Short of a cure, I think really that is the holy grail. And in fact, when I talk about sensors to patients or pumps, I think the question I get asked most is they say, oh, so it does everything for me. And I say, oh, I wish it did. But again, you know, one thing I love about this type of technology we're talking about, Steve, we're not talking about 20 years from now. It might be 20 months from now. I mean, who knows? So the JDRF recently sponsored a study that I know that you're familiar with, where basically they had people in a hospital setting, you know, for this experimental model, and they had a sensor and a pump that had a computerized interface. And what they found is they could achieve excellent, not just good, but excellent glucose control without user intervention, right? So that, like an artificial pancreas, overnight. People aren't eating overnight, they're not exercising, and they found that worked beautifully. The level of sophistication, the type of insulin we have, we're not quite there yet for closing the loop, having a true artificial pancreas for daytime yet. But I think as we get the technology better, I think as the computer modeling gets better, and as we get more rapid insulins, I think, you know, we're getting closer and closer to having that closed loop during the day as well.
Yeah, and there's lots of barriers. As we were talking about before the show, just the differences in day-to-day activities that we do, but also I'd say a big difference is the insulin. The insulin that we inject under our skin acts too slowly to react like a person without diabetes. And I think that brings up the whole concept of technology to tweak medications. So advances in technology is just not just plastic devices and electronics, it's actually tweaking medication. We've seen an advancement in our fast-acting insulins. You know, we have Humalog, Novolog, Apidra, which are faster than the older regular. We got better basal insulins, the topic of a previous show. But we also have a medication called Byetta. This is a medication approved for type 2 diabetes. It's meant to be taken with the 2 main meals a day, so you have to inject it twice a day. And it does a lot of good things. It lowers the weight, it lowers the glucose. But tell us about...
I think that's a key point,
Yeah.
is that it's one, I mean, again, I feel so badly for my patients sometimes. I tell them, you know, Mrs. Smith, Mr. Jones, you've got diabetes, we have to control it. You're overweight, it would be really helpful if you could lose some weight. Here's some medication that's going to make you gain weight. I say, oh, but Dr. Bloomer, you just said I have a weight problem. I said, yeah, you're right, I'm sorry. And that's the problem, you know, is that so many of the medications we have to lower blood glucose, they work well, but they don't help people lose weight. If anything, they hinder it. So one thing I like about this type of medication, this class of medications,
Yes.
is that they make it easier for our patients who need to lose weight, but still, it's 2 injections a day. So, you know, what is on the drawing board? And
Yes.
it's involved in clinical trials. I know
And this is really dramatic. I can't wait till you tell our viewers about it. I'm excited about it.
So, like, I've currently got patients in a research study, and I believe you do as well, where it's the same medication but modified in such a way that people can give it once a week. And, you know, if I tell a patient, look, there's a medication you have to give several times a day, but it's going to help you lose weight, this and that, patients are, you know, they say, hey, that's interesting, doc. If I say, and this one you just give once a week, and they said, 1 medication, 1 injection once a week, they say, hey, Dr. Bloomer, if that's going to help my glucose control and make it easier, not easy, you know, in diabetes and the word easy shouldn't be in the same sentence,
right,
but easier to lose weight, then, you know, sign me up. So I'm really hopeful that this long-acting medication proves to be safe. It was certainly in preliminary trials, it seems to be safe and effective. And if the longer-term, larger studies, you know, bear that out, then I think it's going to have a very important role to play.
And this is just a great example because this substance, as we discussed on our previous show, was discovered sort of by accident in the saliva of a Gila monster. Then they synthetically made it, and they realized it mimics a natural hormone. So the whole discovery and development of this drug and the once weekly is pretty tremendous. And as you mentioned, this comes from a class of compounds called incretins. And I've actually heard that they're working on a once a month formulation.
My wife's a rheumatologist, treats a lot of people with osteoporosis, and now they have, you know, once yearly medication. And I don't know if we're going to see that in diabetes, but I think certainly, you know, more and more research is designed not only for effective drugs, but drugs that are easier for people to manage.
And I think that's the theme. Simpler, easier, combining devices. And
with effectiveness.
And of course, safety and effectiveness. Well, we're coming to the end of our show, and I thought I'd give you the opportunity to leave some final thoughts.
Well,
with our
thanks,
viewers.
Steve. So, you know, I think these are great, but I think the point is that, and I know you know this, and I think every healthcare provider does, the point is that these are complementary to the basic fundamentals of diabetes management. And I can't emphasize how important I think it is, and I know you do, that people with diabetes receive expert advice about how to manage their diabetes from trained diabetes educators, because nutrition, lifestyle, exercise, those are always going to be foundations of good diabetes management. And all these things, they're great, and I'm looking forward to them. They excite me. But the basic tenets of diabetes care, they're always going to be there.
Thanks, Ian. Well, I'd like to offer a special thanks to our sponsors for supporting Taking Control of Your Diabetes. It's their support that makes all of our programs possible, including TCOID TV. More information on technology and the horizon of diabetes care is on our website at www.tcoid.org. Be sure to check it out, or any of our upcoming conferences that we put on around the country. If you have any questions or comments, be sure to email me at askdre@tcoid.org. So remember, you have the main responsibility for taking control of your diabetes. You are your own best advocate. Be smart and be persistent. So goodbye for now, and until next time, take control of your diabetes. You owe it to yourself and your family. Being diagnosed and living with diabetes today is truly a world of difference compared to just a short time ago. In addition to the availability of newer insulins and medications, there have been tremendous advances in technology that will continue to make a positive impact on diabetes care.